I think first we'd like to take a moment to do our own land acknowledgements from the areas that we traditionally work on. So I am located in Ottawa, which is the unceded territory of the Algonquin Nation, home to many diverse First Nations, Métis, and Inuit peoples. And Laura, if you'd like to.
Hi there. I am a white settler who lives on Treaty 1 territory. And Treaty 1 is the traditional lands of the Anishinaabe, the Asininu, the Innu, the Dakota, the Dene, and the homeland of the Métis Nation.
So just a brief agenda for today. So we are going to just kind of give everyone some information on health data, as we realize that there could be people coming from various backgrounds here today. So just want to make sure that, you know, we're all on an even playing field. And then we're going to talk about the benefits and the risks regarding health research and how to mitigate those risks and harms, and then have some time for discussion. So the objectives for today are to recognize that biases do exist in data and identify strategies to mitigate those risks of harms caused by health research to individuals and communities, as well as identify strategies to respectfully use data. So what's health data? So health data encompasses a wide range of information related to health, health services, and healthcare systems. And it can be collected from a variety of sources and used for different purposes. So we, on a daily basis, interact with health data, whether it be through using the health systems, so a hospital or emergency or a rehab center, whether we be doing some clinical lab testing, whether we're participating in population health surveys or information that is collected through patient surveys. And there are also other forms of health data that we may interact with. So some private organizations may collect data. For example, every day that you interact with your phone, you may have mobile health data being collected. So what are administrative health data? Administrative health data are collected and maintained for operational purposes for the management and overall support of the healthcare systems to support patient care. So the data are primarily gathered for research purposes, but they can be used for research to study trends and assess the effectiveness of healthcare interventions. So there are health data providers from across the spectrum, so hospitals, regulatory authorities, provinces and territories, private organizations, international organizations like the World Health Organization collects health data, residential facilities, and many other organizations, like I said, through mobile health. And these data are accessed in various ways. So there are some data that are publicly available for people to consume, whether that be patients, caregivers, even researchers. There are also administrative data, like I said, that are collected through secondary purposes through the healthcare providers and organizations. We also have data requests and data access agreements and data sharing agreements, which are ways in which healthcare organizations can share data and to help make improvements in health outcomes. But what's important to know about these types of sharing agreements is that all the access to health data by researchers and others are governed by provincial legislation to protect personal health information. So this applies to the collection, use, and disclosure of personal health information. So very rarely would we ever be able to identify an individual in data when using that data for research purposes. And some examples include the Personal Information Protection and Electronics Document Act, the Personal Health Information Protection Act, and there are much more different legislation, and these are governed by provincial and territorial bodies. So how are data used in health research? To inform clinical care, to assess the risks and benefits of new treatment and interventions, study trends and patterns, surveillance, outbreak monitoring, planning for health intervention, policy making, resource allocation, and planning. So what about health equity data? Health equity data are generally there to help reduce disparities in health outcomes between different groups and populations. And these usually represent the social determinants of health. So this could include things like age, education, income, sex at birth, sexual orientation, housing, and so much more. And we've had a lot of opportunity to hear more about those as well from this morning's sessions. So health equity data are critical for developing targeted interventions, policies, and programs aimed at reducing disparities in health. And these are really useful in mitigating health inequities. But there's also a risk to collecting health equity data. And so we have to be very mindful about how we're collecting this information and how we're using it. And so Laura will speak a little bit more about the benefits and risks regarding health research, specifically as it relates to health equity data.
Thanks, Carrie-Anne. So thus far, I think that the benefits of doing health research is pretty clear. And the use of administrative data in health research allows for much larger sample sizes because it is potentially more inclusive of those hard to reach populations, because theoretically, everyone with a health number would be included. So there are also many risks associated with using health data for research. Many of these we will discuss in more detail later in this presentation, but one important aspect to consider is that there is poor and in many cases no informed consent from the people whose data is being used. When using administrative data exclusively, people's representation in research is reduced to their interactions with the healthcare system, which is largely deficit-based and is hardly a fulsome representation of their lives. So because of this and many other reasons, if not designed with equity in mind, well-meaning research with health data can perpetuate and sometimes even worsen health inequities and often erase the experiences of people. So let's take, oh goodness. How do I go back?
Oh, I'll help you out here. Yeah, this is the red button.
Yeah, okay. Some of our animation is not working here, but that's okay. So let's take this example where researchers are looking at some level of health and changes after an intervention. The status quo for this type of research is to evaluate health improvement as the primary outcome. So when looking at this data, and this middle line here, you can see that after an intervention, the health outcome had increased. But what the researchers don't know is that when looking at this data disaggregated between privileged people and, say, people experiencing poverty, is that you have two different stories. So before the intervention, as you can see, there was already a health inequity. And after the intervention, the inequity got worse. We also have this instance where the overall health outcome is still the same, but after the intervention, the health outcome for the people experiencing poverty got even worse. So when you're looking at the changes in a health outcome over time, you would say, oh, well, it's partially good because some people got better, but it's partially bad because some people got worse. But what if, from the start, we completely reframed how we did the research and instead looked at the changes of health equity? If we look at the change in health equity, this is conclusive. This was a bad intervention because the inequities got worse. So when researchers and policymakers completely reframe how they look at research and they look at the changes in health inequities, that also changes the types of interventions that are designed. So here we can say, yeah, the inequity got better. And the more we change our mindset towards doing this research, the more we will move towards more equitable health. So it's a complete reframing of how you look at the research. Instead of overall outcomes, we want to decrease inequities. So how can we consider equity during data collection? Administrative data research poses this unique challenge when considering data equity because the researcher is so far removed from the data collection. Because of this, researchers need to be extra vigilant to incorporate an equity lens to the entire research process itself. So here I want to talk about the subjectivity of data. One important part to consider is that researchers may have a false and dangerous misconception that administrative data is objective. This is far from the truth because that data is impacted by how people interact with the healthcare system and how the healthcare system interacts with people. And this represents two really important avenues for bias to be introduced into the research. As an example, we know that alcohol and drug use is not asked about or tested equally among all demographics. This results in one demographic having their data disproportionately reflect alcohol or drug use, when in reality, alcohol and drug use probably isn't that different between the two data sets. Using a personal example, I live in rural Manitoba, which is a farming community. And in my town, we have young people that also come from the reserve. And I know that the healthcare system asks those young kids from the reserve whether or not they use alcohol or drugs. They don't ask that to the young farming boys. And I can tell you from personal experience that alcohol use among the youth in Manitoba is really problematic. But that's not reflected in their data. And that's also not reflected in their experience when they get asked that or don't get asked that by the healthcare system. There's also the opposite situation where patients have to strongly advocate for themselves and return time after time to get tests done and see doctors in order to even get a diagnosis and thereby be reflected in the data. Here, being present in the data represents a really privileged position because you had the capacity and the resources to advocate for yourself, to leave work, to get to the doctor's office. And so this completely erases the existence of the less privileged people who are experiencing the same difficult to diagnose disease. So we know that biased data can perpetuate harms. And when we're creating predictive algorithms, this harm just gets perpetuated through the data. And a final note here is that while administrative data research does not identify individuals, oftentimes its sole purpose is to specifically identify communities. And this can perpetuate harmful stereotypes. When you belong to a group that a study claims to have a worse outcome, that can feel really invasive and it can promote stress and anxiety, especially when you have no means to leave that demographic. And a final note on this here, which came from the New Zealand government, that keep in mind that people often think of the information they have supplied or that is about them as personal, even when it has been de-identified or anonymized and is being used in non-personal form. I know I've experienced this If I find a research article that came out of Manitoba and I'm reading it and I'm going through the inclusion criteria and I realized I'm in this study, and it feels kind of weird because I knew nothing about this, and yet there I am in that data. So now I'm going to turn it back over to Carrie-Anne.
Thank you. Thank you, Laura. So let's talk about how we can begin to mitigate the risks and harms of using data in health research, but also just throughout any sort of data collection. So if we think of data through the data life cycle, we have data collection and stewardship, data processing, data analysis and interpretation, dissemination, and data storage and destruction. And throughout this data life cycle, one thing that really stood out from this morning's presentations was how essential engagement and partnership is at every single stage. So making sure that you have your key partners involved in data collection to data storage and destruction allows you to mitigate those risks. So when considering data collection and stewardship, who is responsible for the data and how will the data be collected? So important ways to mitigate risks at this stage is ensuring that your healthcare providers are well trained and have gone through processes to know how to be safely collecting the data and information. So one personal example is recently, a couple years ago, I was admitted to the hospital because I had my first anxiety attack. And it was quite distressing for me. But at the time, the healthcare provider sat down at my level and asked me if I was okay. That type of care and empathy made the world of a difference for me during my healthcare admission. And I could only hope that everyone receives that type of care, but I know that that's not necessarily the case. So making sure that healthcare providers are well trained in how to collect data. Another important piece is ensuring that you provide an explanation to people as to why this information is being collected about them. This goes a long way. Why are we collecting this information? What do we plan to do with it? And how will it be safeguarded? When we look at data processing, this is when we're cleaning and transforming the data to be used for analysis. So there are a lot of different things that we could consider at this stage, but one critical step would be to look at how data is being categorized. Is it meaningful for analysis? So this morning during your session, actually, we were talking about how certain populations and groups may want to report through their community or may want to have a distinctions-based approach. So what is meaningful to the people that you're collecting information on? So being really mindful about this. How are missing data being handled? And are we perpetuating any biases by how we're categorizing information? So again, this morning we talked about always having the reference category being a certain group of people when that may not always be appropriate, especially when we're considering health equity data. During data analysis and interpretation, at this key stage, we're trying to analyze data and improve health outcomes. But again, as Laura mentioned earlier, are we not just improving health outcomes, but are we also reducing disparities in health? So it's really important to consider those two things. As well, how is the data being interpreted? Are we considering the context around the information? And how are we releasing that information? So one core example that I had was a few years ago, actually a decade ago, I used to work for the Public Health Agency of Canada and would do research on HIV surveillance. And at the time, we would produce these reports on populations at risk for HIV. I didn't realize at the time how harmful and potentially stigmatizing these reports would be. And they were being disseminated publicly, through our Public Health Agency of Canada on these groups who are at risk for HIV. Later on, the Public Health Agency of Canada changed their approach. We built engagement into our framework, and that changed the story. So we started developing these metrics, but instead of releasing them in a public health report, we gave them to the communities who could then action that information in the best way possible. So they looked at doing more education and work with their communities rather than having the information be potentially stigmatizing to different population groups. So this was talking about data dissemination. So also having a process in place when you are releasing that data to make sure you have engagement and partnership to consider how how patients are being represented, how are we releasing the information, is there an approval process in place? So I know, for example, in Ontario, the Institute for Clinical Evaluative Services has a great process in place to make sure that whenever folks are conducting research on Indigenous populations, that they have engagement with the communities themselves. So, and the approvals before any of that information is released. So there's a lot of different things that we can put in place to protect and mitigate harms to individuals through research. And then finally, at the data storage and destruction stage, it's really important to be mindful of how data will be protected and the privacy of individuals. And I know that our sessions later on with Donna will speak a lot to this around privacy and protecting individuals' personal health information and how the data is housed over time to make sure that we are not unintended disclosing that information. So now I'm going to pass it back off to Laura, who's going to speak about mitigating risks and harms throughout health research.
So before I get into that, I'm going to speak just a little bit here about how the data is really handled. It's important to note that across the provinces and territories, there are data centers and stewards, and that's where the data is all housed. And it's housed there in big servers, and then when researchers want to use the data, first they have to get approval from their ethics board, and then they have to reach out to each of the data approvers to access their data sets. And it's really important to note that they can only access the data that is specific to the research project. And so here, these data approvers, which can be the government, cancer care, vital stats, they're essentially acting on behalf of the public and granting consent on your behalf. And so while the data stays in the repository, the researchers can access that data. And it's that data that will eventually be destroyed after so many years. But data centers have a lot of safeguards in place to protect your data. So what actions can we take? Here we're following the We All Count framework, which if you do research, I highly recommend you check out the website We All Count. And historically, I would say that public engagement, when it first started, it came right at the end. Oh, how do I go back? This one? Yeah. There we go, sorry. It came right at the end. But what we're proposing is that researchers engage the public and have meaningful partnerships all the way to the start of the entire project, which begins with funding. I could go on and on about funding and how we need to advocate for better equity in research through funding. But we need to engage the communities throughout the entire research cycle. So here, this is the big slide. There's not much on there, but this is a big slide. So during the project design, you need to ensure that you have stakeholder engagement. This includes community partnerships, but it also includes decision makers. A key to equitable research is resulting action. So we need to stop doing research just to do research. We need to do research that results in action. And if decision makers aren't willing to take that action, then you need to reframe your entire research project. However, those actions need to align with the community needs and desires. This includes even the selection of health outcomes and positive health outcomes and the variables. Choosing a desired outcome is a big assumption that researchers make, and it often doesn't align with the community's desires. This further attempts to warp communities into a paternalistic, oppressive structure. I'm going to give an example of this as the historic handling of the drug problem. Originally, it was thought that the best way to move forward was to eliminate access to drugs. And this just pushed the people who rely on drugs into the dark corners, it perpetuated stigma, and it worsened harms on our communities. The harm reduction approach came out of the voices of these communities. Sorry. And it has actually been further requested by some people in these communities that we stop using drug use as just a harm. For a lot of people who use drugs, using drugs was the only thing that saved their life. They were disregarded by so many aspects of our healthcare system, and the drugs helped them survive. So when you are constantly hearing that this life-saving thing is a risk, is a harm, that's really not very just, and it's further alienating, and it just perpetuates stigma. So addressing these barriers in which the way the system failed them is also an effort towards social justice. So data biographies. Data biographies are associated with data sets, and it covers all of the how the data was collected. So who collected the data? Was it the result of a test? Was it a result of someone's decision? And it has all of the experiential knowledge and nuances of how patients engage with the system and how the system engages with the patients. And this information is collected from data collectors and community partners. And it informs researchers, but at the same time, it can inform the healthcare system of what they're doing incorrectly. So it's one step to create these data biographies so that we can use an equity lens to look at the data. But if that's where it stops, that's not very just either. We now have this data that says people are being treated by the system differently. And so how can we now change the system so that these data biographies are more equal for everyone? So analysis. One way of considering equity during analysis is to create and use auditable algorithms. And these algorithms would allow for close scrutiny to identify any areas where bias could be introduced and perpetuated. Another important aspect of equitable data analysis is the consideration of context. If you have race and income data, for example, use that data wisely. Your model may indicate, for example, that Black people and white people who are living in poverty have the same outcome, and therefore it's not a result of racism. However, if Black people are disproportionately present in the people experiencing poverty, then racism is still a factor. So we have to take that in consideration, and unadjusted odd ratios and proportions do have important meanings. So the final two areas where action can be taken is through the communication and distribution of research findings. The results need to be contextualized in a way that reflects the experiences of the communities within oppressive systems. Strength-based language and the naming of oppressive systems is key to reduce stigma and alienation and shifts the blame off of the person and onto the system that has shaped their own harms. The results also need to be accessible to communities. This means accessible language and targeted reach of the products. Seeing and hearing the voices of community members in the research products is critical, because when people see their own voices reflected in the work, it can increase the feeling of self-determination and shift the power. This in and of itself can positively impact their health. So in closing, health equity data and research are valuable in understanding and addressing health disparities and health outcomes, and access to health services among different populations. Health research can pose both risks and benefits to health equity. It is critical that the risks of health research are mitigated, and there are various strategies to mitigate the risks of health research, especially as it pertains to health equity data. And I think the underlying factor that we talked about throughout is we need to have meaningful partnerships with communities. It's not enough to just have partnerships. Remember that the treaties were formed in partnership. Meaningful partnerships have mutual trust and respect, and there is a reciprocity in those relationships. And this takes time. And so if you're new to it, I highly recommend you reach out to your local SPORE support unit. If you're a member of the public here today and you're hearing us talk about community with partnership with the community, and you're like, well, I would like to do that, I would suggest that you also reach out to your local SPORE support unit. And I think that's all.
That's it.
Thank you. Thank you. Does anyone have any questions?
Sure.
I think so. I think we can.
Okay.
Hi, everyone. Andrew Pinto from the Upstream Lab and University of Toronto. Fantastic work, and I'll definitely be bringing this home to influence the work that we're doing. I was wondering if you could, there's a lot of similar thinking to a new framework that emerged during the pandemic, created by the Black Health Equity Working Group called the EGAP framework. And it's meant to be for, it recognizes the specific aspect of Indigenous data governance and sovereignty. And so other communities, it is not tied to sovereignty in the same way, but it's the idea of still engagement, governance, access, and protection. Something that I've been really interested in and would love your thoughts is how to enable this within each province and territory in a way that doesn't overwhelm communities, because there's a risk that every single health, like if you, in that circle, there's so many different actors that it can really overwhelm communities, and they're doing this without a lot of support. So what's your thinking about how to create this type of engagement in a way that doesn't make it overwhelming for communities, and also is ultimately efficient and in terms of not duplicating a lot of the same steps?
Yeah, that's a really important question. And I know even in Manitoba, our Indigenous data sovereignty team is called FINISM. And they've said, you know, we have all of these grants that are being put through that get approved, and they say they're going to work with the Indigenous data sovereignty team, but they don't see any of that money, right? Grant money goes to universities, and it doesn't go back to community groups. It doesn't go back to the Indigenous data sovereignty team. And so that's where I said I could talk for ages about the funding, because we need funding agencies, we need the governments to recognize this and increase the capacity of those groups, number one. And I think it's also, when we talk about, like Carrie-Anne had said, the collection of these social determinant of health data. The point in which that's collected is really important because a person needs to feel safe to provide that data. But then how can we ensure who's going to be that data approver, right? That comes back to the data approvers. There's been, suggestions of registries, which always makes me cringe, but where the communities basically are the owners of the data, they can approve who accesses the data and therefore have involvement. But we have a group in Manitoba called Spectrum, and we have lots of community groups involved, and they don't have the capacity. So we are trying to work with, we have a partnership grant to try to increase their capacity, but it's going to take a revolution of how all of this data is handled. I also want to say one more thing as well, because in Manitoba, for example, everyone's data is there, but the Indigenous identifiers are held by the Indigenous Data Sovereignty Team. So if you want to disaggregate that data based on First Nation status, Métis status, you have to get their approval. And it's quite difficult, as it should be. But you can use data from Child and Family Services, for example, and not partner with the Indigenous communities. However, in Manitoba, over 90% of the children in the foster care system are Indigenous. So as the bare minimum, they don't have to do that. As a data steward, we can direct them and strongly encourage them to, but it's another one of those things that we're trying to grapple with. How do we encourage meaningful partnerships and that data handling? So we're thinking about it, but I think we're a long ways away from having a good hold on that. Do you want to say something?
Yeah, I was just going to add is continuing to advocate for patient engagement at higher levels, and really considering how to change the system. Like you said, we need to sort of reframe how we think about how data is collected, and I think it really resonated with me when you talked about how are we considering the health outcomes for for everyone in this research, and how are we reframing how we're using this data and how we're releasing it. So I think patient engagement is very important at all levels, and continuing to advocate for that, with our government and with healthcare systems. So I think it's a long journey, but it's worth it.
Presentation. Thank you so much, Kanaskomtanena. I have just a couple of reflections. I really just want to witness, honor, and acknowledge your person first language, rather than a drug user, a person using drugs. And so just keeping that humanity, because they are our relatives, right? And then I really like that framing of because I know when working within Indigenous communities, so many folks, yes, we have some of the highest rates of substance use, but did you know that we have some of the highest rates of abstinence-based recovery? No one knows that. But yeah, we do have some of the highest rates of abstinence-based recovery. And I know that when I enter into Indigenous communities and want to talk about a language of harm reduction, it feels like that them and us, harm reduction versus abstinence-based, right? And then from my own personal story, who struggled with alcohol, is I look at them as a health-harming coping strategy. Because I couldn't deal with the system. Growing up in Alberta was harsh. And rather than having the tools to fight against that systemic racism, because I knew my place in society as an Indian. Because Indian always had an adjective: dirty Indian, stupid Indian, drunk Indian. And yeah, I was a drunk. But every day that alcohol helped me live another day, it was living, but it was harming me. So I think we have to develop, and I know that BC-CDC is adopting this health-harming coping strategies when looking at substances or other behaviors. They're just coping strategies that we must tell our relatives, put down that tool and equip them with other tools. And I found abstinence-based worked for me, and that was my coping strategy of dealing with the world around me. But I really, the other narrative that I just want to, like, the farmers versus the native folks in the screening around substance use, right? And as someone who is like looking at, and I'm trying to develop a new method on how to do a health research, because I don't think that the current research evaluation are, like, it's just around survey designs. Like, is the research goal clearly articulated? Well, if it's a damaging bad research question, you can articulate the goals. Like, a pig with lipstick is still a pig. It's bad. I think we have to come up with different assessment. But what I also find is that in this assessment around the knowledge and what is considered knowledge, the gold standard, peer-based recovery, peer-based journal articles, is that many folks look at placeholders like myself who are Indigenous, who are Two-Spirit, who are this, who are that, as being drunks on the cusp of getting HIV, dealing with housing precarity. And it opens up a narrative that we need savior and saving. Where I just got back from the 13th annual Two-Spirit powwow. 5,000 people showed up. And we're still dancing. Like, we still know who we are. Like, the ultimate act of resistance is that we're dancing. We don't need no savior. And why aren't researchers understanding why are we still dancing today? Because had the colonial project been realized, we would not be here. Or two, we would be here and not know how to dance. We wouldn't know who we are as a Native people. Why aren't we leaning into that discussion? And so I find, like, the conversations on social determinants of health, it's like we're not taking on the conversation. It's colonial policies and settler colonialism that has made us, like, lean into that, solve that's the problem, rather than positing it on the individual that where we need saving. So that it's really complex, but, like, the depth of what you're saying is I'm really hearing what you're saying. And I just, like, wanted to say thank you so much.
Thanks. I also want to point out the injustice of the fact that in academia, when you submit a manuscript, it goes off for peer review of academic peers. And if research is involving communities, should those reviewers not include people from the communities? It's just another one of those systemic problems. I could rant for days.
Yeah, and I think too, like, when we focus on just quantitative methods for data, we also lose sight of, like, the stories, and we just see numbers. And I think that's why it's really important to use mixed methods, so that you get, like, a fulsome picture and you get the stories and the context. And I think we can do a better job at that as well, like in the research community, is kind of using different approaches, and, like, strength-based versus deficit-based. And so I think there's a lot of opportunity to grow and keep learning in the field of research.
Can I say one more thing to that? In Manitoba, we have Peguis First Nation that has created their own legislation around their child authorities. And so they have autonomy over that. And as part of their system, not only has it been an overwhelming success, but as part of their data capture, they are capturing triumphs, which, especially when it comes to child and family services, triumphs are not represented in the data. It's very deficit-based. And when you think about your health data, you, a person, when did you go see the doctor? It was probably a bad time. And so when you show up in these databases, it was this rough day, this rough day, this rough day, this rough day. And there's nowhere in that data collection process to say this amazing thing happened. I am now walking again. I am now doing this. It's only the deficit-based things that happen. So really trying to, when we, in the process of changing everything, we'd also like to have that sort of data available to us as well. Sorry, there's a question right here.
Yeah, hi, thanks. I'm Claudia San Martin from Stats Canada. Really appreciated your talk, all of them. I've learned a ton today. And So as an agency, as a big, large federal department that is trying to do more in terms of putting out disaggregated data for folks to be able to study inequities, we have done a lot more consultation. Sometimes we listen, sometimes we don't. There's lots of factors that go into it. But I would be very interested in hearing your thoughts on the model you like. How does that translate for big organizations? Are there best, we have our consultation processes, but for large organizations that mostly national, federal, have to solve, have to address the needs of many, I'd be interested to know in your thoughts on how we can do better given the mandates we have.
Yeah, that's a great question. It's a tough one, and I think, I do recognize that, pan-Canadian organizations like Stats Canada and the Canadian Institutes for Health Information are trying to use this approach with more engagement. So I know at Stats Canada, before they release any type of research or study, that they would kind of send it off to key partners for approvals, or just to make sure that they have no concerns with what's being shared. And I know even at CIHI now, we're taking a more proactive approach in where, certain data, we won't share it unless we have engagement or partnerships in place. So for example, any data related to First Nations, Métis, and Inuit individuals won't be shared unless we have proof that there has been engagement that has taken place. And I know with HDRN Canada, so they're also looking at a inclusion, diversity, equity framework and accessibility framework. So they're building a strategy on how we can incorporate these components in the work that we do. How can we, model research that is based off engagement, that really prioritize equity and these different types of considerations. So I think it's a slow process. I think having collaboration, engagement between different organizations and discussion on how we can, begin to build sort of a more robust or a more equitable system for everyone. And I think as well, over time, just having more people at the table, having that circle engagement. I think it really starts there, and eventually, hopefully, like Laura said, we'll change the system.
Yeah, I think that we also have to consider the levels of engagement, right? You can check the box of engaging with the community if it's a one-way conversation. But I know with the work with Spectrum, for example, we're creating research teams that include government, community groups, including Indigenous community groups, and academics, and understanding that those are three very different power holders. And you have to be committed to leveling out those power imbalances. And that takes a lot of time. And the best work that we do as a partnership has a very short agenda, because you can't have agendas when you're forming partnerships. You have to just get to know each other and really hear the stories. There's so much about listening, today. And understanding that all of us here in this room hold a very large amount of privilege in order to be able to do research, to ask the questions, and understand that it's a very vulnerable position to not be able to shape how research is done and how your data is collected and handled. And I know one of our IDEA team members in her organization, Lisa's with CIHI? At CIHI, they are undergoing a huge strategy to incorporate IDEA as well throughout. And it takes a lot of listening and forming of the partnerships and changing how we do the work completely. So I really liked the movie screening idea as well. I know we have an idea community of practice with HDRN, and we are taking an unlearning club that came out of BC's Ministry of Health, and their unlearning club included all topics of reconciliation, so it's kind of like a book club. And so every month, you know, you're given a short thing to read, a quick dip, as they say, or a deep dive, so longer things. And with our idea community of practice, we're expanding, you know, reconciliation to, you know, other concepts of equity, access, and things like that. So we're creating this whole resource list that we're taking people on the journey with us, right? So the one thing we heard out of HDRN Canada when we were doing our idea strategy development is people wanted to increase their capacity in it and they didn't know where to start, right? And so this is kind of one way, is getting people familiar with the waters. And so I think communities of practice are really great to hold someone's hand through when you don't even know where to begin, right? We've watched all the documentaries because this is where our interests lie, but other people don't know where to start. So I think a community of practice is a great way too. I don't know if that answered your question.
Actually, and I had one more thought, but this may be more of a hard approach, but as a data person, another piece is being accountable, like being accountable for providing culturally safe environments and doing measurement within your own organization to, you know, how is your organization performing? Are you culturally safe? Do people feel safe? So that's another potential way to keep organizations accountable. So I know there's a lot of work being done across the country around cultural safety in hospitals and health systems. And so I think, you know, that would be a big step in keeping people responsible for being safe and for being thoughtful and considerate, and yeah, just trying to be good people, you know, good humans.
And I think, you know, like I think of the elder this morning, Elder Charles, and when he mentioned that eventually the Indigenous people will be sought out again. And I think we find ourselves going back to a lot of those Indigenous protocols as well. And I also like data. And I know how easy it is to get this data in front of you and you get excited and you're choosing variables, and it is really easy to forget what you're dealing with. And so once again with Spectrum, we are doing a lot of these protocols of smudging, of offering tobacco. And I think for our non-Indigenous partners who maybe don't feel comfortable with that, it's every time you go to do the work, you have to take a grounding moment and think about the people that are in that data. And just like if you were to make an offering of tobacco, you speak to who's there, why you're doing it, what's in your heart, and really thinking of your motives, the motives of your group. And every time you do the work, to just take a couple minutes. And if you swap to a different project, stop, think about that project. It's a couple minutes, and at the end of the day, it's not that much, but I think grounding ourselves in the work really, really is helpful.